Hello and welcome to Clean Talk. I'm your host, Brad Whitchurch, and we are coming to you live from the Seal Shield Studios in beautiful downtown Orlando, Florida. It is Wednesday, 3 p.m. Eastern Time, and we're very excited to have our special guest with us today, Becca Bartles, Executive Director from Providence St. Joseph, Executive Director of Infectious Disease Management. Becca, thank you for joining us on Clean Talk today.
Oh, thank you for having me. I'm excited.
Well, we're really excited to have you here. You know that we are an infection control podcast. We love everything infection control, and we're so excited to have such an esteemed guest. What can you tell us about your background and why you're on Clean Talk today?
Excellent. Well, I love infection control too, hence the reason I'm here and have that title. I've been in infection prevention for the last 17 years. Started really as a bit of an accident, actually. I was working as in a temp role for an infection prevention department while I was waiting to start dental hygiene school. And after just a few days of being in that role, really fell in love with infection prevention and ultimately sort of changed my career trajectory. So over the next few years, finished my bachelor's degree in public health, my master's degree in public health, and last year during the height of the pandemic, finished my doctorate in public health, which the timing wasn't great, but I'm certainly glad it's over. So, and I've worked for a number of large healthcare organizations over that 17-year period, and am a CIC certified and an APIC fellow.
Well, I think the timing was perfect because we need you more than ever right now in this role. I think it's fascinating that you started on the dental side of things. Certainly infection prevention, extremely important in dental. And you not only saw that, but you decided to make that your calling. What else can you tell us about your organization, Providence St. Joseph, and what you're doing there to help with this issue?
Yeah, so Providence is a large healthcare system on the western side of the United States. We have 54 hospitals from Alaska all the way down through Texas, Montana, Oregon, California, et cetera. And we have a very large ambulatory presence, a large home care, long-term care presence as well. And so we serve a few million individuals. And we are actually the healthcare system that had the first COVID case in the United States back in January of 2020 at our hospital in Everett, Washington.
Well, a great facility, a large healthcare facility, but I know that you're involved not just doing the good work at Providence, but that you have a more global perspective and arrangement around infection control. What can you tell us about the Academic Pathway Committee? What is that? And tell us about your involvement in that.
Absolutely. So creating infection preventionists, building new infection preventionists has always been one of my passions. And back in 2016, the University of Providence actually built a master's degree program. We worked together to create a curriculum for infection prevention and epidemiology. It's one of a handful that exists now in the U.S. Prior to that, really, any infection preventionist or person wanting to become an infection preventionist had to do that by landing a job in infection prevention and getting on-the-job training. And the learning curve of transitioning from being a nurse or a microbiologist or a public health person into the role of infection preventionist is steep and really takes a couple of years of on-the-job training. It's not the best way to train someone in such a specialized field, and often there's gaps at the end of the training period. It takes a long time to really comprehensively get the knowledge base needed to be effective in the role.
I'm sure that's true. We've seen the evolution where it used to be the infection preventionists on the floor could just be the nurse that lost the lottery, not necessarily, and we've seen that evolution, and it's great to see that we are educating the next generation of infection preventionists, and I'm fascinated at what you guys are doing to do that. So please continue.
Yeah, and no disrespect to my colleagues that were the pioneers in infection prevention back in the 70s, but I think it's very true that often folks transitioned into a role, nurses transitioned into an infection prevention prevention role as they were sort of coming near the end of their careers. And it's, definitely more of a 9-to-5 job. And, certainly you're not lifting patients and that sort of thing. But over time, that has definitely changed. And the role has become so robust and so interesting and so dynamic that lots of people are interested and really becoming infection preventionists at the very start of their career. APIC has recognized this and done a lot of work over, the last decade on developmental pathways for becoming.
APIC, the Association for Practitioners in Infection Control, right? For our audience members that aren't familiar with that acronym,
yes.
Right?
Professionals in Infection Control, that's right. So that's our professional organization. And so a lot of work's been done through APIC to define what an infection preventionist is and sort of the competencies that someone needs to have in order to be successful in their career. And now through the Academic Pathway Committee, we are taking the next step of actually translating that into academic programs. And so that group, Chaz Roan is my co-lead in that group, co-chair. And then we have represented infection prevention leaders and infection preventionists from across the U.S., lots of different settings, pediatrics, ambulatory long-term care, et cetera, folks new in their career and folks nearing the end of their careers as well. And our group's been working for the better part of a year in developing sort of a 3-tiered approach to an academic entry into infection prevention.
Yeah, go ahead. I'm sorry. I was going to say, you said the better part of a year. This is relatively new, right? That
yes.
We haven't seen this approach in the past. APIC's been around for a long time. They've been doing lots of good work, but this active approach in preparing, as I said, the next generation of infection practitioners, this is all relatively new, right?
That's right. That's right. I think that certainly universities recognize the needs and have begun to develop these programs. Often the infection prevention piece of the program gets tagged into something like an MPH degree or a nursing degree, but hasn't been offered, except with a few exceptions, as a standalone degree program and more of a supplement. And so really the challenge that APIC gave our committee was try and understand what the need is and then build programs around the need. And so we've taken this 3-tiered approach, first being an internship program that's kind of a rapid training to take somebody with little or no infection prevention knowledge and bring them to the point where they're able to do the basic things that an IP needs to do, sort of compressing those maybe the first 6 to 12 months of their career journey into more of like a 10-week period. And certainly that's based on the APIC competencies and the CBIC, which is the Certification Board of Infection Control competencies. And we package those together with sort of the didactic approach along with observations that individuals need to make as they're doing that training, and all of the resources, because as IPs, we know there's more resources out there than any of us will ever be able to digest. And so part of that program is helping folks understand what those resources are so that they can get them when they need them. That was released earlier this year and is available now so that any organization that wants to sponsor an internship program is able to use that to develop their curriculum and sort of bring IPs along in a very standardized way. So we worked on that first because the need is urgent for IPs in the US. There's simply not enough of us. And so built that, released it so that institutions can really start bringing folks to the table and training. Longer term, we are in the throes now of building out 2 additional programs. So a certificate program that would be an adjunct to a master's degree, and then a Master's of Science in Infection Prevention degree. And again, using those same foundational principles of competency, et cetera, but putting it into a formal curriculum that touches all of those things that infection preventionists need to know, so that after 2 years, you graduate and you're boots on the ground, able to do the work.
Now, is this the first degreed master's program for infection prevention?
It's not. There are a handful in the U.S. That
Not
sort
many.
of, not many. No, I think maybe 5, and all very sort of organically grown. But this program it's a template for a program, and so the next step after finalizing the content is reaching out to universities and helping them to see the value in adding a degree like this. And so I think we can expect over the next few years for those programs to, and it's really already happening, those programs to begin popping up, and a career in infection prevention becoming a real option for folks, where at this point, many people just aren't aware it even exists as a career path.
Well, I think there is emerging greater awareness. I think COVID has shined a light that's at least provided more awareness to the greater population on the need for infection prevention. Can you talk a little bit about your experiences of infection prevention during COVID?
Yes, we joked a little before the call that PTSD is a thing, and talking about the early months of COVID. Really can be a little bit difficult for infection preventionists, because those times were so trying and scary, and there was so much lack of clarity in what the right thing was, what the right thing to do was with this novel virus. And we certainly learned a lot. And a lot of those learnings are coming into play with monkeypox. And, you can sort of see that the way that organizations are responding to monkeypox is very much informed by the lessons that we learned during COVID.
Well, I want to get back to monkeypox. I know we're starting to hear about monkeypox, and I want to get your take on that. But we talked a little bit before the show. Infection practitioners, infection preventionists, we had been excited that we were making progress. And then COVID came along and H.A.Is took a turn. And now we see hospital-acquired infections increasing again. To what do you attribute that?
Oh, it's a perfect storm, really. And looking at CLABSI, which is central line-associated bloodstream infections, and CAUTI, catheter-associated urinary tract infections, specifically, we refer to those as device-associated infections. When we look at those, you can sort of picture a pie chart with a number of factors that have put us in a place where we've seen rates increase in the U.S. About 50% since the start of COVID.
Astounding.
After so much progress over the last, 10 to 15 years. And it's multifactorial, just like all things in infection prevention. So when early in COVID, our processes were in great flux as we adapted to the crisis and the staffing and environmental services practices, environmental cleaning. Some facilities chose not to have environmental services workers go into patient rooms because, at first we didn't understand how what the mortality was going to be with COVID, and we ran out of respirators, and so we needed to really sort of lock down the amount of PPE we were using, and that impacted environmental cleaning. Staffing, absolutely. We've had staffing shortages throughout COVID, prior to COVID, but exacerbated as some folks have even left healthcare because of the stress associated with COVID. So environmental cleaning, lack of staff, product shortages, not just PPE, but all sorts of product shortages have come about from issues with plants closing in other countries due to COVID, issues with getting products over here because of transportation concerns, et cetera. And then really looking at the COVID patient as a unique type of patient. So it's not often that we prone patients, but in COVID patients, it's a very common practice. And proning a patient makes it harder to bathe the patient. It makes it harder to visualize the central line insertion site. It makes it near impossible to secure a urinary catheter well, because that pressure on where the securement device would otherwise be placed is problematic. And COVID patients tend to be more diaphoretic and are more likely to have diarrhea, more likely to have secretions. And so, picture this ICU with not enough people, an incredibly sick critical patient, and lots more bioburden in the environment because the patient's creating more bioburden and there's less resources to clean the environment. And that all sort of comes together with in this perfect storm, where the infection preventionist who would otherwise be on the floor auditing practices are stuck in their offices creating educational materials, reporting to all of the state departments of health and CMS and CDC on rates, and putting out all sorts of other fires, dealing with exposures, et cetera. And that's not the whole story either, actually, because you would think that once we got out of a surge, that all of that would return to normal, right? And all of those
factors. That was going to be my question. So now we're coming back to normal, right? Not
right.
True?
So why didn't our rates go back to normal? And what we're finding, my team has spent the last year going hospital to hospital and doing really deep dives in units that have had rates that have been sustained at higher levels than prior to COVID. And what we're finding is that perfect storm fundamentally changed practice in some ways. And you had new folks coming on that were trained in sort of critical nursing practices, and some things were missed, like bathing in a lot of ways got deprioritized, and bathing is so critical to prevention of CAUTI and prevention of CLABSI, linen changes, things like that, and the amount of education, reinforcement of key concepts kind of fell by the wayside a bit. And so we've been left with this impact of COVID, that has sustained over time. And I think really each organization that's struggling with those increased rates has to go to the bedside and watch practices and ask questions and really observe and try and understand what is the specific practice change at that facility, because it's different in every facility.
Well, it's unfortunate that these outcomes are persisting as a result of COVID. Have you seen any COVID silver linings? I talk about the awareness. At least it has brought awareness where it didn't exist before, in certainly outside of our world. But have you seen any silver linings? Has there been anything that we have improved or addressed or made better as a result of the pandemic?
Yeah, absolutely. Absolutely. We have seen much better sort of structure and organization around aerosol generating procedures. It's an area previously where, the state of California had a very strong structure and set of rules around, but most states didn't. And really, we've begun to sort of understand and embrace this idea of an aerosol generating procedure being a risk with all sorts of viruses, not just COVID, flu, for example. And so I think those learnings will help us in the long term to be able to prevent transmission within the hospital of respiratory viruses to both patients and caregivers. I think infection prevention as a profession has been elevated by COVID. Within the first week, maybe, of being on the job, after sitting in my desk, 16 hours at a time, I told my husband, I'm like, this is so exciting and so terrifying at the same time. And he said, it's your Super Bowl. It's the Super Bowl for infection preventionist. And it really kind of was. It gave us visibility where really nobody knew what infection prevention was prior to COVID. So it's up to us now to not let that go and to take advantage of that and really solidify our place as an incredibly important, critical part of the healthcare system.
Well, I don't know about the Super Bowl, maybe the Sick Bowl, but it's certainly time to shine. What about some of the conditional issues? You mentioned the supply chain, you mentioned shortage of PPE. Have you seen that change? Are we getting the PPE equipment that we need now? Are the supply chain issues clearing up? Any movement there?
Absolutely. Lots of work done there. And some things feel normal and like they've returned to normal. And I'm not sure if folks on your show have discussed in the past those very early months of COVID when we ran out of respirators and we ran out of masks. We had folks. I mean, my organization actually took over a furniture factory and brought surgical wrap and sewed masks. We had dozens of people sitting at sewing machines and cutting and sewing homemade masks for our caregivers. And so when we think back to that and the fact that we were buying marine grade vinyl and tape basically and making our own face shields, we're in a much better place. Product availability is much better. The manufacturers have geared up production to sort of meet what is the new norm. But product shortages happen much more frequently now than they did before. And I'm talking about other clinical products outside of PPE. And honestly, I think we're just kind of getting used to that being the way it works, that you walk into a supply room and there's a little sign up in the bin where you expect to see one product and there's a replacement next to it that's probably not quite as good. But another benefit of COVID is folks have become infinitely adaptable to those sort of things.
Well, you talk about infinitely adaptable. I've heard stories about facilities implementing new technologies so that they could reuse PPE, whether it's ultraviolet radiation or some way to repurpose what's supposed to be disposable or personal protection equipment. Did you have solutions like that as well? Or, I mean, this is the first time I've heard about buying a furniture store so that you can make your own solutions. I love that approach. Was that the only recourse? I mean, at what point are you in the meetings when you just say, I guess we have to buy a furniture store? I mean, it's got to be.
Right. And to be clear, we didn't buy it. It was actually the owners were wonderful and provided that resource to us. We are Catholic healthcare, which inherently means we don't have extra money. And so they're beautiful people for really stepping in and helping us keep our caregivers safe. But yes, we tried all of the options. And it was that same sort of uncertainty where it seemed like every day we got new recommendations from our various regulatory and advisory agencies saying, you can do UV. Oh, wait, no, don't do UV. You can do ETO. No, wait, don't do that. The government actually put some ETO sites out across the U.S. and built processes for us to bring our respirators to them for decontamination. None of that really worked well. It was all done as part of the crisis, and it was necessary, and it kept our caregivers safe at the time. But it was hard, it was labor intensive, it was confusing, and absolutely not something I would ever choose to do if there were another option.
We have a question from one of our viewers. Let's take that now. So Kevin Bradshaw says, we've developed a new bedside barcode scanner with infection control in mind. It was featured a couple of weeks ago on Clean Talk, and we'd be very interested in the best way to contact the infection control care team at your healthcare facility. So we'll be sure to connect you, Becca, after the show. Can we discuss offline? Kevin will be sure to get back to you on that. Sounds like a good opportunity all around. You had mentioned before, Becca, monkeypox. We're all now starting to hear about monkeypox. What can you tell us about monkeypox?
Well, it's exciting. It's keeping things in our field new, and there's always something new to do every day as an infection preventionist. I think there's also Lanya virus and polio out there this week as well. But monkeypox it's having its heyday across the globe right now. I think this morning I saw 9,500 cases in the U.S. so far. We're definitely sort of hopefully nearing the top of that epidemic curve. But it's where it's a cause for concern because it is absolutely a risk. The morbidity is low, the mortality is low, and it's not a cause for panic. Certainly, I don't think we're going to find ourselves in a resource-stretched place with monkeypox like we were with COVID. Most patients presenting with monkeypox come in through the ED or an urgent care setting, and are discharged from there. Don't require hospitalization, and most folks go on to make a full recovery. And so, where it's concerning, it's novel, and it's taking up a lot of our time, making sure everybody knows the processes so we can prevent exposure. It's hopefully something that will be in the rearview mirror much sooner than COVID will be.
Well, monkeypox probably won't be the next pandemic for us, but I find it really amazing what we were able to do during COVID in terms of developing a vaccine and getting it deployed, in terms of developing the testing, getting it deployed, being able to produce more ventilators very quickly. My concern is that none of these things will help us in the next inevitable pandemic. What do we do today to help to continue to reduce infection rates?
Oh boy. I think a lot of those things will help in the next pandemic. We know that we have the capacity to do really amazing stuff when we're put under that type of pressure. And I think that, truthfully, healthcare turned into a startup for a few months there as we tried to build and do all of these things in response. And I think that we will take forward, and that will be really useful to us. Outside of that, I think that we have lots of opportunity in the realm of public health, and providing the resources that our colleagues in public health departments and the CDC need in order to be on the lookout for novel pathogens and be able to stop them from entering the country, or likely not able to stop them, but to certainly slow the process, and then have really robust exposure and contact tracing resources in place so that we can limit spread, versus finding ourselves in a place where things have gone too far for us to be able to slow things down before we're even aware of it.
And how do we get there? It has to be a combination, public and private. And I know that we have put some additional, maybe the first infection control funding. There has been some budget, certainly for nursing homes coming out. Is that the solution? Does that help? What is it going to take for us to really be able to develop the solutions that we can have best practices moving forward that will give us at least some general protection in the future? Do you have any sense of what the magic bullet is that we need to really make a change?
Yeah. Oh, if I could wave my magic wand, I think that I published a paper a few years ago where I assessed staffing needs for infection prevention in hospitals. And what we found when we looked at all of the tasks an infection preventionist needs to do their job well, that one IP per 69 beds, 69 occupied or available beds was...
We're not close to that now, though, right?
Oh, no. No.
Not even close.
Yeah. And I think, that's step one for sure, is staff our hospitals and our long-term care facilities. We understand that more than we ever did prior to COVID, how important it is to have infection prevention and long-term care. But to bring our staffing levels up to a point where infection preventionists aren't always putting out fires and responding to emergencies, but we are being proactive and planning and really able to follow up on hunches and all of the things that we're really good at that we don't get to spend a whole lot of time doing. Couple that with building stronger and more robust public health department response teams and communicable disease programs, which once we get into the world of political science, we're out of my area of expertise altogether. But I think coupling those together absolutely would take us much further down the path. And I'm really hopeful that that's one of the silver linings that comes out of COVID.
Well, I appreciate that you've identified that need for the resources and that you're taking the action in association with APIC along these lines to help encourage and educate the next generation of infection control practitioners, infection preventionists. We do have another question from our audience, Becca. Jordan Bureau asks, is there concern for viruses like polio coming back? Even though there's been a vaccine for it for years, is there a worry that viruses like polio will become vaccine resistant or mutate? Is that a risk?
Um, I'm not a virologist, and so I absolutely can't speak to the properties of each virus and risk of mutation and becoming vaccine resistant. But in general, we do find ourselves in a place as a country where vaccine has become a political issue. And, it used to be, it's always been something infection preventionists have struggled with, helping folks to understand the importance and the safety around vaccination. But COVID has brought us into a completely new world of where this is it's falling along political lines. If we continue down that pathway and that mindset merges or mingles in the world of other vaccines, absolutely we can find ourselves 50 100 years in the past looking at at large polio outbreaks. I mean, we've seen measles outbreaks, we've seen chicken pox outbreaks, but we can find ourselves in a place where these diseases where we thought we had eradicated them in the United States become a real concern again. I'm hopeful that science will win out here and that, we'll be able to continue the dialogue and rebuild trust with the public regarding the safety of vaccines. But it's a scary thing to think that we could struggle with polio again in the United States this many years later.
Yeah, I agree. And it is concerning that so much of this has become more political than science. And I hope that you're right, that we're on the right track. I hate to give you concern, but I can tell you that it's becoming pretty political on the solution innovation side as well. So hopefully we'll be able to overcome that and work together towards the global good when it comes to preventing these pathogens and cross-contamination infections in general. But we have made a lot of progress. Things are changing rapidly. We've been forced to change rapidly. Any final predictions for the future?
Oh boy. I predict we will see more novel viruses and we will find ourselves in a place again where we're having tough conversations and stretch resources. Hopefully not in our lifetime will we see another COVID. But I think that, we tend to cycle through this once we lose awareness and we lose focus on being prepared, we find ourselves in a place where we're not able to respond effectively and quickly. And so I am very hopeful that at least for my generation of infection preventionists and really healthcare leaders across the US, that this will help us to maintain a focus on preparedness and the importance of infection prevention, vaccine, et cetera, for an extended period of time.
A message of hope for Becca Bartles, our guest on Clean Talk today. Becca, I really appreciate you being on the show. It's been a real pleasure. Thank you for joining us today. And thanks to our guests for joining us today. Be sure to join us every Wednesday at 3 p.m. Eastern Time when we come to you live from Seal Shield Studios here in Orlando, Florida. Until next time, I'm your host, Brad Whitchurch, for my guest, Becca Bartles, reminding you to keep it clean.